So what I want to do is thank you for spending some time with me. And the purpose of this is to clear up the misinformation, the disinformation, um, the lack of complete information of the proposed uh, change to a retiree Medicare eligible health coverage. I want to put it in the proper historical framework so you understand what's going on and why it's being done. Then I'll talk a little bit about the proposed plan. I say proposed, and if I say new plan, I mean new proposed plan, because negotiations are still going on between the two finalists. There are two finalists out of four that bid. One is Aetna, and the other is what we're calling the Alliance. And it isn't anything from Star Wars. The Alliance is a joint effort between Emblem Health and Empire Blue Cross, which are our current primary vendors. So you've got Aetna, which is also a current vendor, and this alliance between the other two. So before I was born, and before, so of course, before I knew there was New York City, back in 1946, New York City put into the administrative code that all active employees and eligible dependents, as well as retirees and eligible dependents, would get free basic health care as long as they lived. You retire from the city of New York, you still maintain the health care. There was a question here. Is this the same as on the recording? It should be, yes. So New York City is providing free basic health care to everybody, all municipal workers and retirees. As far as I know, there is only one other group, municipal entity in the country that provides free health care to active employees, and that's the Los Angeles County Schools. Everybody else pays something for health care. Years ago, I was at the assistant principals conference, and a couple came out from having a brunch, and we were talking, and they said one of their children was a teacher in San Antonio, Texas. And at that time in San Antonio, Texas, the school district paid nothing towards health care. If you wanted health care, you paid 100% of the cost. So two sides, both ends of the spectrum, and so we're at the end that we do have free basic health care. When it comes to retirees, we are the only group I know of in the country that provides free basic health care to eligible retirees and their eligible dependents. This is something that New York State retirees do not have. The last figure I heard for New York State retirees was that they pay somewhere around 28% of the cost of health care. And as you know from your active days when you're and dealing with negotiations, in every negotiations, there's things, and every year it seems they go up another couple of percentages. So more and more of the cost of the burden of the healthcare costs are being paid by New York State employees and retirees compared to what we have. So I want to get that there so that we know what we have. We have something that nobody else in the country has. The current focus on saving money on healthcare started back around 2010 or so when Mayor Bloomberg was still mayor. He came and he proposed a number of healthcare savings options. The Municipal Labor Committee, which is all of the unions in the city, listened, but when he was asked what he was going to do with the savings, he wouldn't commit to putting it back into the workforce in terms of salary increases. At that time, most city unions did not have active contracts. There was a bargaining around going on, and some unions, such as UFT, CSA, and the nurses, were already behind around because that was the 4% increases that all of a sudden Mayor Bloomberg decided they couldn't afford. So this is where we were. Nothing happened. The only thing that came out of that cost-saving initiative was the dependent verification, which hadn't been done for probably 20 years. If you remember back If you had a spouse or partner on your health plan at the time, you got a letter from the city saying, we want proof that you're still together. And, it caused a hubbub, of course. Why did they ask this? Well, what I found was that there are a lot of times a couple would get divorced and the non-city partner would be kept on the health plan because it didn't cost anything. So, Janice and I are married. I'm sorry, Janice, you're in the middle of the screen. Yeah, don't tell Ron. So we're married, and one day she says, "Doug, I love you dearly. I can't live with you anymore. We're getting a divorce. But don't worry, it's not going to cost you anything. I'll keep you on the health plan." And that was prevalent. And so as a result of this dependent verification, the city saved $100 million a year. And so that's continuing. That's part of this health savings initiative. So Mayor Bloomberg leaves office, Mayor de Blasio comes in. And when Mayor de Blasio comes into office, he faces a workforce where no unionized group of employees in the city is working with the current contract. Everybody's contract has expired. So under provisions of the Taylor Law, when the contract expires, you keep working under the terms of the contract. So 152 or so bargaining units all need raises and all need increases. So very quickly, the city came to the Municipal Labor Committee with a proposal that said, we want to save cumulatively $3.4 billion over the next 4 years. And in exchange for that, we will negotiate raises for everybody, and CSA UFT nurses will settle for that round that you're behind and then bring you up current. So in that was included that $100 million from the dependent verification. There were a number of other things. There was some pressure put on our primary vendor, Emblem Health, to keep the HIP rate lower than maybe they would have liked, because that's the benchmark rate for active healthcare. And if you lower that, then you save some money. And there were other initiatives. The emergency room deductible was increased to $150. The walk-in, like City MD or walk-in medical deductible was set to $50. If you were in the GHI CBP plan, you had increased copays for both regular or primary care doctors and specialists. You were enticed to go to a group called the Advanced Physician Group, which Emblem has invested a lot of money in, and thus keeps the cost down. And all of those things together accounted for saving $3.4 billion in healthcare. Now, what didn't I mention in that first round of healthcare savings? I didn't mention any impact on retiree healthcare or retiree healthcare costs. So the first $3.4 billion in healthcare savings was achieved through changes to active employees or pre-Medicare retirees, nothing affecting Medicare eligible retirees. So now in 2018, with the success of exceeding the goal of $3.4 billion, the city comes back to the union to say, we want another round of healthcare savings. This time it was to be $2.1 billion over 3 years. And what was created in this agreement was what's come to be called the Tripartite Committee. And what it is like it says, it's 3 parts, 3 groups. One group is the city, one group is the Municipal Labor Committee, and the third is an arbitrator. I believe his name's Howard Scheinman, who's very experienced with the city and with healthcare and how the city health plan works. And their stated goal was to come up with additional savings that will preserve free basic healthcare for active and retired employees. One of the proposals they had, which was very quickly tossed out, was to introduce a tiering of hospitals. because now hospitals are the largest expense in that plan. No surprise, Presbyterian is the most expensive hospital in the city. Langone, Mount Sinai, Sloan Kettering, Hospital for Special Surgery, Northwell, they're a little bit less, so they would be a second tier. And then health and hospitals, the city-owned facilities would be the lowest tier. And they were proposing a deductible for maybe $2,500 per visit for Presbyterian, $1,000 for the tier 2, and if you went to a health and hospitals facility, it would be free. That was quickly thrown out because a lot of doctors who may be affiliated with one that that people would go to may only have an affiliation with Presbyterian. So if you needed to be hospitalized under your doctor's care, why should you be penalized because your doctor only has privileges at Presbyterian? So that was tossed aside. And a number of other things, some additional copay modifications for active members, further control of the rates from Emblem for HIP and GHI. And they also said, well, let's get $600 million a year of savings on our retiree healthcare plan. And how can we do that and have the minimal impact on our retirees? Because not every retiree in the city of New York has a pension, a TDA similar to what we have. So they're very mindful of the effect any change would be in terms of cost. So what was proposed and what was put out to bid in an open and competitive bid was a new type of Medicare Advantage plan called a passive PPO. This is completely different than anything you're familiar with. And that's why saying Medicare Advantage raises so much angst. The typical Medicare Advantage plan, like you see Joe Namath advertising on cable television, or even HIP VIP, those are very restrictive plans. They say that you can only go to a network provider. You can only go to a specialist if they refer you to that. Every little test has to be referred and justified. That is not what is being proposed here. What's being proposed here is a group Medicare Advantage plan, and it's called a passive PPO, Preferred Provider Organization. And the fundamental difference between what's being proposed and what we think of as Medicare Advantage is that as long as your doctor participates or accepts Medicare, this plan will cover that and the plan will pay. So if Aetna is the chosen vendor and your doctor is not part of an Aetna network, you don't have to worry. Medicare will pay and this new plan will pay the 20%. So there's no restriction. Nobody's coming to tell you you have to switch doctors unless you want to. Nobody's telling you you need to have a referral to see a specialist. Most tests, as they are now, can be done without approval. And if there is an approval, it's up to the provider to get the approval. And if it's later denied, you don't pay for it because it's on the provider to get the approval. So it's completely different than what you think of as Medicare Advantage. As somebody, our Florida liaison, Norm Sherman, said, can't you call it something else other than Medicare Advantage? I wish I could, but this is what Medicare calls them. And since it's under the guise of Medicare, if they say it's a Medicare Advantage plan, it's a Medicare Advantage plan. But it's a passive PPO. Any doctor that takes Medicare, you can go to, and Medicare will pay their 80%, and this plan will pay the 20%. The 100 days of rehabilitation services that we have now, those will be included in the proposed new plan from either vendor. And an improvement to the plan is that the 365 days of hospital coverage, which technically is part of the optional benefits rider, will now be part of the plan. For the last 20 years, the welfare fund has paid that hospital benefit for any Medicare retiree in the GHI Senior Care Plan. We've done that for 20 years. Since 20 years ago, a lot of our members had a spouse who was covered by private business as a retiree, and the co-pays and the cost of drugs was much less through that than through the city plan. So people wanted to use the spouse's drug plan, but didn't want to give up the hospital benefit. So we negotiated with labor relations for us to pay that. So we pay that for anybody tagged as being in the CSA Retiree Welfare Fund in the senior care plan. So it'll save the fund a little bit. It's down to $1 a month now, so it doesn't break the bank for anybody, but it's still something that will be included automatically. There will also be, because of the different focus of this plan, the focus of the proposed new plan is on wellness and well-being, not necessarily just paying claims if you're sick or injured. So as a result, there will be a mobility program of some kind. It could be Silver Sneakers, which is available if you're in the HIP VIP plan. But there will be access to a mobility plan. Why? Because if you stay mobile, then you have better joint health, you have better cardio health, you have just better health all around. There'll be focus on nutrition, healthy living and all. One of the vendors has said that if they're selected, they're willing to have a representative go, if asked by any participant, to their home or apartment and go through and find any potential health hazards in the home. So, for example, if somebody comes in to look and they're in your bathroom, and yes, you got the grab bars and everything, but they see a bath mat that doesn't have the sticky stuff so it doesn't slide, they might suggest you get a bath mat so you don't step on the bath mat when it's wet, slide out and break your hip, as one of our members recently did. Look at other potential things that could be hazardous in the home. Also included in the plan is expected to be some form of providing meals to you if you're hospitalized and then come home. The research has shown that if you're hospitalized, you come home and you have proper diet, that speeds the recovery and you get a much more satisfactory recovery. So by sending you a couple of 3 meals for a period of time, then that gets your health back and will help cut down on things such as readmissions to the hospital. And so there's a question here. So how does Medicare save money on this? Well, they save money by putting in these things. If you're mobile and you keep your balance and you keep your health up, that reduces claims. So they save money. If you eat well, that saves money. The main point is that under this proposed new plan, the new plan will be paying the claims, not Medicare. What happens now is you go to the doctor, you see the doctor, they send the claim to Medicare. Medicare pays their 80%, and then they electronically send that to your secondary coverage, which in this case, if it's a regular doctor visit, would be Emblem Health and GHI. Then they process it and send you paper. So right now what happens is every once in a while, with no rhyme or reason, Medicare sends you an explanation of benefits of claims they've processed for you in the last whatever period of time. And all the way over on the right-hand side is that dreaded "you may be billed" column. And you say, why would I be billed? What that "you may be billed" is, that's the 20% that Medicare doesn't pay. And then a couple of 3 weeks later, you get an explanation of benefits from GHI, and they've paid that 20%. So Medicare does that. It's also easier for us as participants because we have one point of contact. If you've ever tried to deal with Medicare and then deal with Emblem or Express Scripts or Blue Cross, it's not much fun. I did it Tuesday for my wife for a variety of reasons. And after talking to United Healthcare on the drugs, then I had to deal with Medicare. And I'm still waiting for the call back from Medicare that I'm supposed to get within 7 days. So it just, it's an easier point of contact. If this is approved, And the approval process is nothing that's just like overnight. Because once the small group of city and union folks who are working on the negotiations come up with who they think is the winning vendor, it then goes to the what we call the technical committee, which is a group of fund administrators, and I'm on that committee, and the city, and we have to agree that we're behind this plan. Once that happens, it goes to the core group of the Municipal Labor Committee. And just recently, our president, Mark Cannizzaro, was named treasurer, was elected treasurer of the MLC. So he's now part of that core group. It was just recently, so this was all in process before he got involved, but we now have him in the core group. After the core group says, okay, then it goes to what they call the steering committee, which is a group of maybe 15, 20 union presidents. If the steering committee approves, it then goes to the general membership, which is all 152 unions. So it takes a while, and all the way through, there is an approval process. Once it's approved, it's not going to happen July 1st. You know, I guarantee you that. I'm willing to bet my life on it, because July 1st is only 6 weeks away, and we haven't even gotten to the point of knowing who the selected vendor is. The earliest it could be implemented would be January 1st. So what happens if everything goes through and they say, okay, municipal retirees, the base plan now is the Medicare Advantage plan. And this is the plan that we will provide, as we have to under city law, free of charge. You don't have to take it if you don't want to. However, if you're not in the benchmark baseline plan, there will likely be an additional charge to stay with what you currently have. Okay, so there will be a charge to remain in the GHI senior care. At this point, I have no idea what it is. I don't want to say what it is, because if I'm too low, you'll say, but you said, and if I'm too high, you'll say, what the hell was he talking about? It's only this. I've heard ranges, I've heard wide ranges, but until we see the final proposal, when we see how it comes in price, and what the price difference is between this proposed plan and the current plan, that'll determine how much, if you want to stay in one of the other plans, you have to pay. There is an upcharge or an additional charge now for plans other than HIP or GHI. If you're in the Aetna plan that we currently have pre-Medicare, your pension deduction is $5,900 a month. And there are people in that plan. How you're in it with $5,900 a month and living on a pension, I don't know. Other plans, Empire plans, a Cigna plan out in Arizona are a little bit less, but they all require some kind of upcharge. So it's not something new, it's always there, and it'll be up to you to choose. There'll be a chance, just like there is now, every 2 years you can change back and forth between plans. You know, it'll still be there, so if you don't do it at the beginning, yeah, and maybe, you can switch later. If you switch first and then you say, no, I really don't like it, you'll be able to switch back to something else. Let me see, I see there's a lot of questions here, which are good. Problem is that I see them and it distracts me. So let me go back up here to the beginning. Since the city's renegotiating going forward, will the new company be allowed to change the definition of basic health care without going through the process with the unions? No. What is in a health plan is determined cooperatively and jointly between the city and the unions. So the city can't come in and say, we're cutting these benefits unless the Municipal Labor Committee agrees to it. And like I said, that's a long process. That's the people on the committee that I'm on. That's the principals of the union. That's the general membership. So they can't just come in and decide, no, we're not going to cover this anymore. It has to be negotiated. Um, when visiting doctors, you show the new Medicare Advantage card. That would be the card you would show. You'd still have the Medicare card, but you would show the Medicare Advantage card. It's expected, as anytime you change things, that there will be some hiccups and speed bumps and glitches along the way. Everybody's card will have a concierge phone number on, so that if the provider says, I don't know about this, they can call and talk to someone trained to explain it. Emblem Health in particular is getting better at providing this level of service. One of the things in the current round of healthcare negotiations is that anybody who's a new hire to the city, regardless of position, has to be in the HIP HMO plan for 1 year, because that's the least costly plan. And the way they've re-envisioned it, we're at the point of after a year, there's 95 to 98% retention, meaning someone who was put into the HIP plan when they first came in decides to stay with it when they could change. So Emblem in particular is developing a better capability of providing the support. And between whoever the vendor is, they would be able to resolve that. So it would be a new card and everything would be done through that one card. Which benefits would be lost or limited? Really nothing. And what's at the point now in the negotiations is with both of the finalists, they're going down through and they're working, saying, well, senior care has this, or what do you have? What do you have here? So they're matching up to ensure that we don't lose anything in doing this process. We had a question, can you keep the current coverage? What would the premium be? We don't know yet. I don't know what the copays will be. There will be some minor copays, most likely. I've heard $10, $15, which is not unusual. The HIP HMO, which a number of our people are in now, the HIP VIP, they have, I believe, $10 for a regular doctor, $30 for a specialist. So these are their, when we see the final plan, we'll know what the deductibles and emergency rooms are. I expect they'll be very comparable to what they are now, because the design, the goal of the whole process is to come up with a plan that looks and acts just like what we have now, but is less costly to the city. How does it save money? I think we talked about that. With Medicare contributing and funding. How the doctors know it's new plan, it's same as Medicare. There'll be education to the providers. There'll be education from Medicare, I'm sure, to the providers. There'll be information that you can give your providers. You don't need a new Medicare card, you'll still have the Medicare cards. We talked about premiums and deductibles. Are physicians going to be paid less than under current Medicare plan? Absolutely not. Because what the physicians are paid now is the Medicare allowable charge. So, it's still Medicare. It's still Medicare and the supplement. It's just that, it's called a Medicare Advantage PPO rather than GHI Senior Care. Okay, if you're not yet eligible for Medicare, then this isn't going to affect you. It'll affect you when you become Medicare eligible. One of the things that's being worked out now is something that happens very often, and so far hasn't really been a problem, because not everybody is equally as mature in the couple. You may be more mature than your spouse or vice versa. So you may go into this and one person is Medicare eligible and the other isn't. Right now, it's not a problem. You have GHI CBP for the non-Medicare, GHI Senior Care. The city knows this, they know the premiums, and they make the appropriate pension deduction. If a plan that a company comes in that isn't familiar with doing that, then they have to find a way to do that. And both finalists are working on developing a proper way to handle the what we call the split contracts. UFT says it costs at least 170 more a month. UFT can say whatever. I've heard that, I've heard less, I've heard more. And until I know, I don't want anybody coming back and say, well, UFT said it was 170, and you said it was 100, and it's 165. So why were you so wrong? I have no idea. I have no idea until we see what it's going to be per person for the proposed new plan, which will become the benchmark, compared to what it is per person for the senior care. And it would be probably whatever that difference in cost is, that will be the upcharge to be into that plan. Will you be covered if you're in another state? Yes, this plan works around, it will work throughout the United States. HIP only works in greater New York. Some of the other plans are restricted, but this is a nationwide PPO plan. So those who are snowbirds, sunspots, halfbacks, whatever you are, you've got coverage wherever you are in the country. The high option rider, there will be a charge for a prescription drug benefit, just like there is now. I'm told it will be less than what it is now. What exactly it will be, we don't know until we see the final bids and final proposals. Do you still pay Medicare? Yes, you'll still pay the Medicare Part B premiums just like you do now. You'll pay the Medicare Part B. You'll pay the IRMA for Part B if you qualify. You'll pay the IRMA for Part D if you qualify. And most importantly, the city will continue to reimburse the Medicare Part B premiums in full, both the standard amount and the IRMA amount. So there's no diminishment of anything there. That's a separate agreement the city and the unions made over 50 years ago when Medicare was first introduced. When it was first introduced, the city realized they could save an awful lot of money on healthcare and still help provide the free basic healthcare, because if Medicare is going to pay 80% of the cost, they only have to cover 20. So the union leadership in the city at the time negotiated and said, okay, if we agree that our Medicare eligible retirees will be covered by Medicare primary, you have to reimburse their Part B premiums in full because you're still saving money. The city agreed. So everything was fine. It was the state. Everybody paid the same amount up until about 2005 under the second President Bush. And then they introduced the idea of means testing Medicare, and that's where the IRMA came from. And I'll tell you, it was a few interesting months sitting around the table with the city and no fund administrator willing to ask them if they were going to reimburse IRMA. So when they said they were and didn't bat an eye, we were all very relieved. And that will continue if there is a new plan. Medicare Part B premiums will be continued to be reimbursed. If you stay in HIP VIP, it'll be the same charge it always is now. This proposed plan is a successor to the senior care plan, the GHI senior care plan. Okay, it did GHI senior care. It's accepted in other states. Okay, if the basic health plan is free, what's the $150 deduction from the pension? That's the optional benefits rider. That's the prescription drug benefit. You need to be in some qualifying Part D plan when you're Medicare eligible, or Medicare will penalize you. You don't have to be in this one. And that totally only pays for the prescription drugs. As prescription drug costs increase, as we take the latest and greatest medication that's advertised on TV, as opposed to a generic or an older medication that's been around, the costs go up. The drug manufacturers have exclusivity through patent controls for a period of years when they introduce a new drug, and they charge whatever they want to. They're talking now in Congress about pricing of Humira. which has been around for 15 years at least and treats a number of conditions. But since there is no generic, they can charge whatever they want. The impact on prescriptions is that it would have a different formulary. You might have to change your medication, but the important thing is that all the therapeutic categories will be covered. So diabetes, high blood pressure, cholesterol, they'll all be covered. We talked about copays. If we want to change after choosing this plan out, when could someone pay? I don't understand that question, but you would be able to change. I don't know if they're going to be continue with the every 2-year transfer period, as we've done in the past, or if, since this will be so closely tied to Medicare and Medicare's enrollment requirements, that you'll be able to change every year. That's something that we still need to get some clarity on. Chemotherapy is going to be covered. A lot of chemotherapy medications now are covered under Medicare Part B because they're infused medications. There's a little bit of home care in Medicare now. It's still the same Medicare. And we'll still continue our welfare fund benefits to supplement some of the things that may be added to the plan would be maybe some minimal dental, but that if there's any dental, it's just cleaning and exams, which we already give you 4 of those, 4 cleanings and 2 exams a year. There may be some support for hearing aids, which can only help. You get $800 from us, you get $800 from the retiree chapter. If there's additional money coming from the health plan, that suits you, and that's a benefit for you. You pay a monthly fee for GHI. The fee you pay for GHI Medicare eligible is the optional benefits rider. There will be a corresponding fee. I'm told it will be likely less than what it is now. Medication, drugs, and formularies. Until we see the final plan, we don't know exactly what they'll look like, but there will be a formulary. There is now. Medicare has a formulary, and that's what Express Scripts deals with. With the senior care plan. So whatever the formulary is, we'll figure out what it is. We'll help you, and if there's a way to appeal, we'll certainly help you try to appeal. As soon as you start copays, they tend to keep going up. I agree. And the goal and the mission of those of us on the union side of all these negotiations, because remember, the city can't just increase the copays. The plan, whoever the final vendor is, can't just increase it. It has to be agreed to between the unions and the city, and the unions will work, diligently to avoid increasing copays. Will it be? I don't know how the ID card is going to look. I don't know if it's going to say PPO. There will be a phone number on there for providers to call and get correct information for billing purposes and coverage. Doesn't affect IRMA. Yes, it'll be a Part C Medicare plan. But even if you're in a Part C Medicare plan like HIP VIP, you still pay for Medicare Part B. So there's really, you're still going to be paying that Medicare premium. We talked about the healthcare savings and what Medicare is contributing. It says, somebody says, it seems illogical that if we lose nothing we presently have, there'll be a charge to keep what the present plan is. That's because the proposed new plan will have a lower cost because Medicare is helping to pay some of those premiums. So if Medicare pays whatever, $200 a member a month, Well, that's $200 a member a month the city isn't covering, so that's where some of the savings is the subsidy. Medicare increases the money they pay to an Advantage plan based on a couple of criteria. One is the outcomes. So if you have a reduction in hospital admissions, reduced stay, reduced claim experience, that's one factor. And then also, how do you feel about your plan? And do you feel like you're getting proper coverage? Do you feel like you're getting adequate care? So the better those two ratings are, the more money that the Medicare puts in. Dental, like I said, from what I've seen, the dental may be minimal dental. Our dental would still be more comprehensive. It's a question here about what about out of the country. I've asked for clarification on that. If you're out of the country now, um, the charges are considered out of network, and both Empire and GHI pay a little bit on it. Travel insurance is probably going to be advisable, more advisable now, but we'll have that answer for you shortly. Copays, what copays am I referring to? There may be copays on doctor visits, specialist visits, things in the new plan. That's what I was talking about with copays. The retiree membership doesn't ratify the plan. The plan, like I said, is accepted by the union vote of the unions, and it's a weighted vote. So you get X number of votes for every how many ever members you have. So of course, the bigger the union is, the more sway they have. The two biggest being DC 37 and UFT. But all unions will have a vote, and the unions, I'm assuming, will listen to members and their concerns and look at all of the factors when they decide how they're going to vote for this. Question here, my wife and I have Medicare and Emblem Health GHI. In a nutshell, how will our lives change? Very little. As long as the doctor takes Medicare, you should be good to go. And there should be minimal impact. A question, can you choose any Medicare Part D? With the current GHI senior care plan, you can. With the new plan, you'll have to be in that plan because Medicare subsidizes the drugs, and they're subsidizing the Medicare Advantage plan, including drugs on one hand. They're not going to subsidize the drug plan on the other hand. So it's either stay with senior care, pay whatever additional charge there is, pick your own Part D plan, or go with whatever the new one is. We can't provide any guidance because I don't know what the new prescription plan will look like. If it's approved, it's the passive PPO now primary. It's still the way it is now. You'll present one card to the provider, and when the bill goes to whoever the vendor is, they'll say, okay, this is Medicare's portion, this is our portion, and they'll send the invoice to Medicare and say, pay your portion. Will the options be permanent? Yeah. I don't know why, the proposed initial contract period is 5 years with some options for extending beyond that. Anytime you go into something like this, you're going to want to have, if you're the vendor, you want some assurance that you're going to put a lot of work and money in up front to get the plan implemented. You want to know you're going to be around for a while to enjoy it. So most contracts are 3 to 5 years initially with options to renew. Will CSA and UFT still cover dental, optical, etc., or will the new plan cover those costs? I will not speak for UFT. I'll speak for CSA because that's who I represent. And we're anticipating no changes, no diminution of benefits. um, for those who would be in this new plan. If anything, when we see what's in there, there may be some benefits we can, some other things that we can supplement. There may be things that we don't need to cover anymore because this new plan will cover them in full, in which case we can go and we can expand some other benefits. Or there may be features that we can add to. And like I said, until we see exactly what it is, we won't know what's there. The drawbacks to the new plan, not that I've seen. If I was eligible, I'd sign up for it. What prevents it changing the contract? The city and the unions have to agree to any changes in the contract. Their contract is with the city of New York, and the city of New York and the unions together manage the health benefits. Will there still be a distinction between accepting assignment and participating? Yes, that's still there. Nothing really changes. If the doctor accepts Medicare, he accepts Medicare. If he participates with Medicare, he participates with Medicare. It's just that it'll be a single point of contact for all the billing. Will the formulary list for the new plan be the same as our current plan? I really can't say yet. The current plan is supposed to be enhanced, but it seems like every time somebody wants a drug, they're being denied. So, we have to wait and see what the final formulary looks like. And when we have that, we can do a comparison. What I do know is that every illness, every medical condition will have at least one covered drug. So it's not like if you have high blood pressure, you're on your own. Or if you have COPD or asthma, you're on your own. Every therapeutic condition will have a medication available. Here's a good one. My wife has not received her standard Medicare reimbursement. Who can I speak to? Let me know. Send me an email offline and we'll follow up, because I'm sure we've given our Medicare card to the city. Question here, can I design the chart with the difference between Medicare Advantage and current Medicare benefits? We have asked for that. President Canizaro said that he will not approve going forward with a new plan unless and until we get a point-by-point comparison chart. So that will be forthcoming. Like I said, they're still finalizing the what's to be covered and how they're going to be covered. And once we get that done, then I expect we'll have that comparison chart internally to look at, and then we'll have something to compare senior care to the proposed new plan. Copays were before 65, they were $20 to $30. They stopped. Under the new plan, they may start up again, but we have to wait and see what the final plan design is. Is the union behind? The union, well, Medicare Advantage, the plan that's being proposed is a PPO. So it's a passive, they call it passive PPO. And we haven't taken a position on anything yet because we don't know what we're taking a position on. When there's when one of the vendors is determined to say the recommendation is let's go with this plan, then we can determine whether we're going to be familiar with it or not. Somebody mentioned ASL for dental in Florida and they weren't familiar. That's for Carrington. Let me know. Send me an email. I'll have somebody from SIDS contact you and or the dentist, and we'll get that taken care of. What are the pluses of keeping and paying for the current GHI senior plan? I've got flip answers, but I won't give them. I don't know that there's any plus other than you're reluctant to make a change. If you want to wait a year or two and see how it goes in, that's fine. You'll be able to opt in at the next transfer period. It may be, a financial decision when you see what the monthly premium is. Um, If you have Emblem HIP VIP Prime and you're in another state, are you covered for a medical emergency? That's all you're covered for, is emergencies. Um, and if it's like pre-Medicare, they will initially deny the claim, and then we have to help you go to them and say it was an emergency, and then they'll pay. We had a active member skiing in Colorado one year, broke her leg, was taken to the local hospital, and HIP denied the claim because it wasn't a participating hospital. And when we pointed out to HIP that she was in Colorado with a broken leg, they said, okay, we'll pay it. But their initial inclination was to not deny the coverage, but they did eventually pay it. And we would assist you with any similar situations. Do all unions need to agree on the plan, or will different unions have the choice of staying in the current plan? It doesn't need to be unanimous. It just has to be a majority vote of the unions weighted by the membership. And it's not a union deciding, yes, we're going to have our members be in it, or no, we're not. Whatever it is applies for all city retirees, whether they're from Parks and Recreation. No, that was a TV show, I think. Anyway, if it's DC 37 park workers, if it's DEP environmental workers upstate on the reservoir, if it's teachers, if it's school administrators, if it's law enforcement, everybody who is retired is covered by the city health plans. So it's no one union. If we say no, we're not in favor of it, and the other 151 unions say yes, we're in favor of it, then it's going to apply to our members as well. Copays would only kick in when and if a new plan is approved. Advantage plan super for the city. Yeah, you will be able to switch back to what any other plan later on. Will there be a distinction between Medicare provider and accepts Medicare assignment? It'll be the way it is now, and that's something we will get some more clarification on. There's a standard reason that if Medicare pays more as the administrative insurance company saves costs, that our services, tests, hospitalizations will be denied? No, it doesn't mean that at all. What it means is that Medicare is help funding the benefits and is putting money in and rewarding plans that have successful outcomes and do what they need to do to satisfy their members. Will there be a deductible? I don't know yet if there's going to be a separate deductible after the Medicare deductible. If there is, it's probably likely to be in the range of what it is now, which is $50 a year. Copay could be the biggest difference, yes. When we know the details officially, as soon as we know them. I'm guessing that they were going to want to try to wrap this up by the end of next month, but none of us feel pressured to do so. Our responsibility is to our participants. And if we need additional information and need to have additional things clarified, then we will push to have those. I would guess that the earliest that the new plan could be implemented would be January 1st. It's obviously not going to be July 1st, like the article said. That was the original goal. But with COVID and some of the other things delaying the process, July 1st is obviously not going to happen. It takes a minimum of 90 days to implement a new plan. When we've switched prescription companies for our active members, they've insisted on a minimum 90 days, and that's a push. you could do it more with 120, 150 days, and that would make it a more comfortable implementation. There's a lot involved in doing this. There'll be educational materials and sessions about what actually is covered. When we can say, here's what senior care had, here's what this new plan had, this is what this costs, that's what that costs, this is what's going to be covered. That's going to take time to generate those materials and then have the informational session so everybody knows what they're doing. On top of that, the city needs to update their administrative systems because now they'll have a new healthcare vendor and the new variety of codes they have to create. So they need some systems and programming work on that to do it and test it and hopefully make sure it works and works the first time. So this is all going to take some time. So it's not imminent, but it's just something to keep in mind so that if you see something or know something or hear something, you'll know really what's going on, not just what somebody's put in an email. You have to have a primary provider. No, you don't have to designate a primary care physician, a PCP, like you do with traditional Medicare Advantage. You can switch who your primary care general, internist is at any time. You can go to 3 of them if you want to. There's no restriction like that now. It says now Medicare is billed first, then it goes to GHI. Why is the reverse cost saving? It's not a reverse. It's everything's going into this new plan, and they're paying the Medicare portion, they're paying the supplemental portion all on one check. So it's only one check and it's one person doing the processing, not Medicare processing, sending out a payment, sending information to the secondary, then the secondary processing it again and sending it out. So it's processed once. If you remember back to last July, I know it's hard to think back that far these days, but last July, for those in senior care, both Empire Blue Cross and Emblem Health implemented new computer systems. And they gave everybody new ID numbers that began with the letter K, and that was a whole fiasco. And a separate card now for prescriptions, which is a whole fiasco. But the worst part, what happened in mid-August, we get through the ID number stuff, and then it's like, okay, that wasn't so bad. Then all of a sudden, we're getting reports of people getting their supplemental portion denied by somebody called Empire WGS. And, everyone's coming through saying it's denied. So what happened was when new ID numbers were provided to Medicare for the crossover, Emblem apparently went first and said, here's the ID number. We do the secondary for doctors and laboratories for Part B. And when Empire sent over the information, they should have said they do the secondary for Part A, but they said A and B. So Medicare doesn't know. It's all automated. So they go in and bingo, all of a sudden, all those secondary claims that should have gone to Emblem went to Empire. That'll be avoided because it'll be one company paying the whole thing. All hospitals will be covered to the best of what we know now, and they're finalizing all those agreements. If you want to change, if you change plans but want to return back to the plan, will pre-existing conditions be a problem? No. Under terms of the Affordable Care Act, which really doesn't apply for Medicare-only plans or retiree-only plans, there is no such thing anymore as a pre-existing condition. Okay. We talked about the cost savings. I haven't seen the physician's letter about concerns. The city will be reaching out to the provider groups. They're the sponsor of the health plan, so that would be their responsibility between the city and whoever the selected vendor is. Yes, you can switch. question here. If you decide to take the new plan, will we pay any fees or just fees to remain in the current plan? The only fee, if there's a copay, you pay the copay, you'll pay the cost for the prescription plan, just like you do now. If you stay in the current plan, there could be a pension deduction, as we've said, to remain in the plan you have. Will the deductible be paid reset to zero when the new plan starts? It depends on when it starts. If it starts at the beginning of January, all the deductibles reset then anyway. If we implement this plan after January 1st, then whatever the Medicare deductible has been paid is, the Medicare deductible has been paid. And we'll have to figure out if you paid the GHI deductible, what happens then. Did I say if you take the Medicare Advantage plan, you don't need a Part B? No, you do need Medicare Part B. And you have to pay for Medicare Part B out of your Social Security check or paying directly to Medicare, just as you always did. The only thing you will pay is the optional benefits portion, which is the prescription drug plan that goes with it. Under the current GHI senior plan, does everyone have the optional rider for 150, or is that truly optional? It is truly optional, because the rider is generally whatever's there, you have to take all parts of it. But for CSA retirees, there's a special code. It's called full rider less hospital, because we pay the hospital portion. And we do that so that if you're in GHI senior care and either you have a very expensive medications or you don't use a lot of medications, hopefully, you can choose a less, a better suited plan. If you opt out of the current drug plan, you don't lose anything. You still have the GHI Blue Cross Medicare supplement. You still get the Part B reimbursements. You still get the IRMA reimbursements. The only time you don't get Part B reimbursement is if you switch into a non-city sponsored health plan. If you're so taken by the Joe Namath Medicare Advantage advertisement you see on TV and you decide to sign up, then by being in that Medicare Advantage plan, you are no longer in senior care. And because you're no longer in a city health plan, the city is not going to reimburse your Medicare Part B premiums. The proposed plan is still a city-sponsored plan, and as a result, you'll still keep the Part B reimbursement. Some people can get a cheaper RX plan on their own with the senior care plan. Too many letters. You'll have Medicare Part A and Medicare Part B. The drug plan will be Part D, and you'll be in the Part C plan. So I guess we got all the letters covered up there. I don't think they've come up with any more. Okay. I don't see any more questions in the chat. Have I totally confused everybody? Yeah, okay, good. My mission is I'm successful. Just kidding. Oh, another question, okay. Oh, just a thank you, okay. So I just want, if there are no more questions, what I'll just say is that I hope you found this to be useful. My goal is not to give you inside information or anything. My goal is to give you the facts as we know them at this time. I have seen the emails that have been floating around. One of them, they contacted us and wanted comments. And so our communications director sent me an email and said, what do you think about this? I said, I don't want any part of it. I don't want to be going on record. It's your decision. If you tell me to talk to these people, I'll talk to them. If not, I don't want to talk to them. And as a result, we didn't talk to them. And it was noted in I think it was in the city. It was one of the municipal publications. And it said representatives from UFT, sanitation, whatever, DC 37, CSA refused comment. So that was us. We refused comment. Nothing good would have come out of that. This is where the good comes from. And I wanted to talk to as many people as possible and let you know the facts. So when your friends send you these scaremongering emails, then either you can ignore it or you can try to have a conversation and explain to them what's going on. I've heard UFT has done some similar things. I don't know about other unions, but I'm sure just about everybody has or will be doing them. Like I said, I'm speaking with a number of other retiree units between now and mid-June. Whenever something happens and there's an agreement and we know what we can do, we'll do more of these. Hopefully by the fall, if something is approved, we can do some in-person things. So, purely selfish, so I can get a bagel again. I haven't had a bagel. I haven't had a bagel in a year and a half.
Can I ask a quick question?
Only, huh?
Can I ask a quick question?
Absolutely.
I hope you didn't answer this. I had to step out for a second with work. I think I forwarded to you. I got an email saying from the drug company, the mail order, that you cannot go to your local pharmacy. 0% will be covered. You have to do it through your mail order, which was erroneous.
Right.
I forwarded that to you.
Yeah.
What came out of that? I scare you from going to your local pharmacy.
I have to go back and look in that. It was so long ago, but I'll go back and look and see what we did with that.
They were trying to say that if you don't order from like Express Scripts, then you have to pay 100%. And
well, pre-Medicare, you get 2 fills at a local pharmacy, and then you have to use the mail with GHI. Once you're on Medicare, you don't have to use the mail anymore, and you can get a 90-day fill at a local pharmacy.
What's the difference in price?
Brand names are probably a little cheaper locally. Generics maybe a little cheaper through the mail, but not to the point where it's, oh my God, I'm going to save so much money through the mail.
But that was completely misrepresented.
Yeah, I like I said, I remember the email. I got to go back and look at it.
Thank you.
Not that you bombard me with emails or anything, but
me?
No, not Nancy.
But I do come to all your sessions.
Yes, you do. Yes, you do. You do. We appreciate it.
Still always have questions, but sorry. Yeah. Thank you.
Okay. Anybody else?
Yes, I have a question, Doug.
Okay.
If it's possible that we're going to have co-pays under the new plan and everything else is staying the same, why is this advantageous to us? What is the upside? Or is it basically that we're being forced to negotiate because prices are going up and we have to pick something? In other words, I don't see an upside if I'm going to have co-pays that I don't now have.
Well, the upside is that this allows the city to continue to honor their commitment to free basic health care.
Okay, so basically we have to do something.
Because we have to do something. And considering that the in-service people have committed to, at this point, a minimum of $3.4 billion worth of savings, that are recurring savings, and now it's just, they're saying they're trying to get $600 million a year from retirees. And so it would be, what the goal is to preserve the level of care and the services you receive, but is a lower cost.
Okay. So in order to maintain our current level, we have to take some action.
Right.
Okay. And I just want to clarify, I'm really stuck on this $150. The $150 that's deducted monthly, that is only for our drug coverage. It's not for the supplemental 20%.
No, it's only for the drug coverage.
So I'm paying. So if I'm basically not taking any drugs, I'm still paying $150 just in case, kind of thing. And if I opted not to do the rider, could I do it separate? I have a sister who's doing a drug plan for, under $50 a month.
Right,
I'm
you
just
could do
curious.
that. You could do that with the current senior care plan.
Okay,
So if you want to do that, you'll email me in October. We'll help you find a plan. We'll help you work with the city to drop it.
okay.
Or you see what the drug plan will be with the proposed new plan, assuming it's adopted by then for a January start, and then we can work and see what's best.
Yeah, I'm
for
not
you.
going to make any change now. So there will be some comparable deduction for a drug plan.
Oh, yes. And
And then,
I'm told it's going to be less. I don't know what it's going to be, but they're saying it'll be less.
okay. And then if we wanted to stay in GHI, that would be an additional
On
premium.
top of the
on top of
150, yes.
that. Okay.
Yeah.
Thank you. That's very clear.
Okay, good. Okay, anybody else? Okay, what we got here? Should be coming back every 3 years.
Yes, I
and
want to
following
ask
these
a
days
question.
medians. You
Will
know
these
they'll be
plans-
coming back to the unions every 3 years. They're always asking for givebacks. I have no idea what the new mayor will do. That's what makes it kind of interesting now with the timing. This was planned to have been done before now. It wasn't planned to be implemented the first day of a new mayor's administration at the earliest. So, they're always coming back and wanting more and more and more, but we have to agree to sit down and discuss with them more. The last time, just as we were finishing up the first healthcare agreements, the then Commissioner of Labor Relations came to a municipal labor committee meeting the end of May, and it's like, "See, look at that, we did it, we made it, thank you. Let's talk about the next round." And they told him, take the summer off, come back in the fall, and we'll start talking again. So before one agreement's done, they're looking for more givebacks, and that's always the way it is dealing with the city. It's always the way of dealing with negotiations. So, they're always looking for something, but you got to have both parties willing to negotiate, because they won't be able to go in and mandate anything.
Excuse me, Doug?
Yeah.
Do any of these plans require you to get permission from your regular physician before going to a specialist?
No,
No. So you can go to any doctor.
right. That's the PPO portion. That's the PPO compared to the traditional restrictive Medicare Advantage plan.
Oh, okay.
So
So
It
so
is.
the Medical Advantage program does require that.
the HMO Medicare Advantage, like HIP does.
Essential worker?
Yeah.
The
How are you,
proposed-
Matt?
the
We're good.
proposed
Giving out cupcakes today.
plan- No,
For?
the
Because
proposed
you're here
plan-
and we're not.
proposed,
How are you?
the PPO
Oh,
does
that's
not.
okay.
does not require you to have referrals to specialists. I'm sorry about that.
Okay.
Somebody's having too good a time over there. Yeah,
Okay.
that's the power of being the being the host. I can mute whoever I want to if they get annoying. But I won't mute you, I promise.
Okay. Yeah.
Okay. Anybody else?
Yes.
Okay.
If I'm not mistaken, I think you mentioned the fact that before this new plan comes out, we should get a sort of a fact-finding sheet, like, point A over here, what it means over here for the old plan and the new plan.
Yep. Yes, we will, we will make sure that everybody gets that. To the point that we will mail it and email it, just in case. To make sure everybody gets it.
Okay, will it have the cost over there as well?
Well,
Like the cost of
I haven't seen what they've put together yet, but we'll try to make sure we get the cost there. If there are co-pays, what they are, what the cost is to stay with the senior care as compared to going to the new plan.
Doug,
Yes,
no co-pays for the current plan. Isn't the current plan more cost saving in that case?
it's more cost saving, you don't pay the co-pays, but it costs the city more.
But what about us?
No, well, yeah, you don't have co-pays. But
So wouldn't
yeah.
that save us more money in the long run?
What, instead, keeping in the current plan?
Yes,
Well, if there are co-pays, then that reduces a little bit what the premiums are to the city. So it's a way to share a little bit of the cost without having actual premium.
but as far as we're concerned.
As
wouldn't-
far as, well, as far as you're concerned, if there are no, who knows, they may add co-pays to senior care at some point. That may be part of the whole process. But, right now, the senior care plan has no co-pays and you pay nothing for it. And in trying to save additional monies, there will be co-pays on the new plan as well, to preserve the no pension premium contribution. Okay. Do we have
Are you
anything?
going to post I'm sorry.
Go ahead.
Are you going to post a recording of today's session as you did recently?
Okay, I will. Yeah,
Thank- Thanks.
Where do you
No.
post it? On the CSA website?
it's on the Welfare Fund website. Go to csawf.org. And right on the home page, it says recording of May 12th. It may not be up until the beginning of next week because what I have to do once this is done is make sure that there's no chit chat at the beginning,
Mhm.
and then convert it to something that I can then upload into YouTube and have them convert it so that then I've got a link to go and post on the website. So it takes a while, and unfortunately or fortunately, I have my video editing software on my home computer because I had to edit the video for my daughter's wedding. So I had all the stuff here, and once or twice a year, I use it now for Zoom recordings. And so it's totally an amateur production, but it gets the message across. Okay?
There's a Santa Claus.
Okay, I'm going to stop the recording.